Good morning everyone. Today we will be discussing about medical management of keratitis. In today's class, we will be looking at the definition of microbial keratitis, the causative organisms and features, investigations which are required, management and follow protocols, and when you have to refer. Microbial keratitis is defined as disruption of the epithelium with infiltration of the stroma. Bacterial and fungal together contribute around 95% of the ulcers. Majority of the cases we see are bacterial, which constitute around 63%, and fungal contribute around 33%, parasitic are around 2%, and mixed infections are around 6%. There are two steps in managing an ulcer. First one is a thorough history taken and slit lamp examination. Bacterial ulcers are most common, contributing around 60% of the ulcers. Some of the ulcers are so characteristic that if we look at the ulcer, we can pinpoint the organism. But it should not be taken for granted. The corneal scraping should be mandatorily done to confirm what you have done, what you have seen. In cases of GPC, you look at a roundish, grayish infiltrate which is very well circumscribed. Usually, these patients also have chronic dacrocystitis when you do syringing. In case of a GNB ulcer, it is very rapidly progressive. Mostly the pseudomonas, especially the multi-drug resistant pseudomonas, you see that there is perforation within 1 or 2 days only, and you have to treat them as an emergency. Some ulcers can also have, other ulcers also can have very typical presentations like a ring infiltrate with a lot of pain is very characteristic of acanthamoeba. But mind you that fungal ulcers and other ulcers also can present with the similar fashion. So always corneal scraping is must. The typical wreath-shaped pattern which you are seeing here, like the pinpoint dotted infiltrates which are looking like a wreath, are very characteristic of Nocardia keratitis. Diagnosing this is very important because Nocardia responds very well to amikacin and not to the regular bacterial ulcers treatment. Clinically, guessing the etiology may be difficult sometimes, and so it is very important to always stress upon corneal scraping for coming to the diagnosis. Like in this case, this is a case of fungal keratitis where you have feathery extensions, dry looking margins. But just by looking that, and if you see this picture, if in the first glance it also looks like a similar dry looking and feathery extensions, but this is pythium keratitis which closely mimics fungal keratitis. Why is it important to do the microbiology? Because the treatment for fungal keratitis and pythium keratitis are pole apart. While you give linezolid for pythium keratitis, you have to start natamycin for fungal keratitis. Also, that pythium is more refractory and you should be very vigilant when you are treating that. What are the four mandatory investigations you have to do for any ulcer patient? Always get a random blood sugar because sometimes high blood sugars impede the healing, and you know that everything is going on right. You are giving the patient the right kind of medication. The patient is also very compliant, but still the ulcer is not healing. The culprit may be the high blood sugar. Syringing is very important because you have to rule out chronic dacrocystitis, which again is a very common cause of non-healing ulcer. B-scan ultrasonography is very important for us when you cannot see the fundus if you have to rule out any posterior segment involvement. Also, corneal scraping is a must where you have to make sure that you prove that you are giving the treatment in the right direction. What are the three questions you have to ask yourself when you're managing a case of ulcer? First thing, what are the medications should we start? How do you follow up? And when should I refer? Let's go it one by one. Generally, there are two initial types of treatment for bacterial keratitis which we start, which is the combination therapy. This combination therapy is usually a fortified cefazolin with a fourth generation cephalosporin like amoxifloxacin or a ciprofloxacin. This is the most effective treatment which you can start. This you have to make sure that you tell the patient to start the drops early. But the problem is, the disadvantage of this treatment is that fortified drops have to be prepared every time, and if you are not very well versed with preparation, which is actually very easy to learn, you might feel it very cumbersome. The other thing, if you have a very small infiltrate, like a less than 1 infiltrate, and you're sure that it is bacterial, you can start with a single antibiotic. But it is always better to start on a combination therapy, because your first phase of treatment should be very aggressive. There are two phases in healing of corneal ulcer. The first phase, where there is sterilization of the cornea, where you are maximum aiming at killing up the microbes by hourly administration of antibiotics. And the second phase, where is a healing phase, which is limiting the inflammatory damage, superinfection, and promoting epithelial healing. These are the fortified antibiotics. The most common one we use is the cefazolin at 50 milligrams per ml. As I told you, Nocardia responds very well to amikacin. Uh, if you really want to know how to prepare this fortified antibiotics, just let me know. Then, in case of fungal ulcers, you treat with natamycin, and in case of acanthamoeba, you treat with chlorhexidine and polyhexamethylene biguanide. What are the three important adjuvant medications which we use? First one is the cycloplegics, which is either atropine or homatropine, nothing less than that, because you need really long acting cycloplegics for it. Anti-glaucoma medications may be used if you feel that there is a rise in IOP, and you can give oral analgesics to relieve the pain of the patient. At presentation, it is important to pick up a severe infection. What is a severe infection? Anything which is more than 6 infiltrate with more than 50% thinning, ideally, and you look for if there is any perforation. If there is a perforation, just refer the patient with systemic antibiotics. Whenever there is perforation, ideally avoid topical antibiotics. Suppose there is a 6 infiltration with thinning, but there is no perforation, you can start early drops, and then if the patient is not responding, maybe then refer the patient. Suppose there is a more than 6, suppose it's a small infiltrate, and you can start the patient on OP basis on an early drugs. It is very important to review the patients periodically. When will you see the patient? Ideally every day, if not possible at least within 48 hours. Why? Because it aims at detecting rapidly progressive cases. What is that which you are going to look for when you are looking at a patient in the follow-up? The first thing you have to make out is the scarring, which is an important clue, which will tell you whether your treatment is going in the right way or not. And also look for subjective improvement. The patient always tells that, yeah, I'm feeling a little better, the redness has come down, the pain has come down, and reduced AC reaction. Also look for any reduced lid swelling, reduced conjunctival congestion, and chemosis. In the part of the ulcer, you have to document the epithelial defect, size, shape, and the dimensions. Preferably, if you have a Hack-Street slit lamp with you, you can document the in what is the size of the ulcer, and you have to document if there is reduced size of the epithelial defect, reduced size and density of the infiltrate, and reduced surrounding stromal edema with an onset of scarring. It is a good sign for you. You can keep following up the patient on the same treatment. Suppose your ulcer is healing, and then you continue the antibiotics as said, and you will follow the patient every 2 days, ideally every day, and see, also look for any late signs of progression, and if it is healing well, then you continue the antibiotics. If there is progression, always look if there is any signs of perforation. If there is perforation, always refer the patient for a TABCL or an emergency therapeutic penetrating keratoplasty based upon the size on systemic antibiotics. Suppose there is no perforation, you can recheck the culture. Check if it is culture positive, you can check for the sensitivity of the drug, whether you are using the sensitive drug or not. If you are not using a sensitive drug, then you can restart the whole treatment with a sensitive drug. Suppose you have already been using sensitive drug, please exclude poor compliance. It is very important that you spend that chair time with the patient and explain to the patient that you have to use the drops hourly. Hourly is only 6 or 8 for most of the patients, but you have to spend that time to that patient and tell him that he has to use it minimum 20 to 25 times. Suppose the patient is culture negative and you have excluded poor complaints, you can admit and restart the primary treatment, and you can also send him for rescraping. At 1 week review, if there is a complete resolution, just stop the medication and keep the patient on the follow-up. And if there is no change or progression, just make sure that to recheck the culture. If it is still culture negative, then you can stop the medications for 24 hours and then refer the patient where that will act as a drug holiday, and you can do a repeat scraping and start the treatment de novo. Suppose it is culture positive, then look for the sensitive and see whether you are treating with the sensitive drug or not. If already sensitivity is done, please rule out poor compliance of the patient. And if the poor compliance is ruled out, always suspect polymicrobial infection. If there is poor compliance, better to admit the patient and restart the treatment with sensitive drug. At 1 week review, if there is an incomplete resolution, it is not resolved totally, but it is in a mixed bag. Always suspect a partially resistant isolate. If it is resistant, then you can restart with the sensitive drug. If it is not because of that, always rule out poor compliance. It's always the poor compliance, and as I told you early, if you probe the patient 1 or 2 times, the patient will tell he'll be using 6 times, 8 times, and as he gets better, sometimes the frequency is also reduced. So it's very important that you stress on that patient that he has to use those hourly drops till you have told them to use so. If there is no poor compliance, always rule out other things like dry eye, trichiasis, and you can start the patient on therapy, QID therapy, and review after a week. What do you do in case of indolent or progressive keratitis? Whenever there is progressive keratitis or indolent keratitis, it is always ideal to repeat corneal scraping after a 24-hour drug holiday. It is important for us to pick up any new organism which we have been missing, and that's why the treatment has not been effective. If it comes out to be culture positive, then you treat according to the culture and healing, and then check for the healing in the next coming week. If it is culture negative, you can plan for a drug holiday and do a corneal biopsy. Corneal biopsy is a very it is a very useful thing where you send a small piece of cornea both to histopathology as well as microbiology, and it can help you in detecting organisms in case of indolent and progressive keratitis. If it comes out to be negative, then you have to make sure that you start your treatment again. Keep the patient on check, and if it doesn't heal totally, maybe you'll have to think about a TPK. Also, if it is slow healing and if it's not healing according to the plan, maybe if it's progressing, maybe you'll have to even consider a therapeutic PK. What do you do in case of fungal keratitis? In fungal keratitis, the treatment of choice for us is 5% natamycin. You always start oral antifungals when there is a large ulcer, when there is a central ulcer. You see for the response in 1 or 2 days, mostly after 2 days, and then if you see that there is some peripheral scarring which is coming up, the size of the infiltrate is decreasing, the size of the epithelial defect is decreasing, and the patient is getting comfortable, just keep the patient on natamycin. Hourly, continue the same treatment along with the cycloplegics and oral analgesics and oral antifungals, and keep the patient under follow-up. Suppose the patient is not responding with this, maybe you will have to, if you have if you have access to micro laboratory, you can go for in vitro sensitivity, or you can go for amphotericin or voriconazole, or you can go for intrastromal or intracameral voriconazole or amphotericin B. Now you have to decide whether he is responding or non-responding, and in cases of non-responders, maybe you will have to plan a therapeutic penetrating keratoplasty. What are all the causes you should rule out in cases of non-healing ulcer? Mainly you have to rule out poor compliance, mixed infection, any secondary glaucoma, chronic dacrocystitis, dry eye, any neurotrophic cornea, or any persistent inflammation or lack of thalamus. If these are all ruled out, majority of the healing can be brought back into track. To summarize, careful history and slit lamp examination is the key. Corneal scraping is a must to know about the etiology. Basic investigations you have to do for all these ulcer cases are RBS and a syringe. Make sure both of them are done in all the cases, however small the infiltrate is. Always start with fortified antibiotics in a mixed therapy for a bacterial, and closely follow up the patient to pick up any thinning and non-healing ulcer. Prompt referral in case of perforation and large ulcers is very crucial. What would be the next topic you would like to listen? Please let me know in the comments. Thank you for your patient hearing.